Multiple Myeloma Hub podcasts, brought to you by Scientific Education Support.
Hello and welcome to the Multiple Myeloma Hub podcast. Today we'll be hearing from Jacob Laubach from Dana-Farber Cancer Institute in Boston, US, and Peter Voorhees of Levine Cancer Institute in Charlotte, US.
Good morning. I'm Jacob Laubach. I'm the clinical director of the Multiple Myeloma program at the Dana-Farber Cancer Institute, and I'll be discussing with you today results of the GRIFFIN trial with an updated analysis after 24 months of maintenance therapy. The GRIFFIN trial was a randomized phase 2 clinical trial in which transplant-eligible patients with newly diagnosed multiple myeloma were randomized 1-to-1 to receive either standard RVD induction therapy or RVD plus Daratumumab. Patients received 4 cycles of induction therapy, followed by a single autologous stem cell transplantation, and thereafter 2 cycles of consolidation with either RVD or Daratumumab plus RVD, followed by maintenance with either Daratumumab and lenalidomide or lenalidomide alone. The primary endpoint of the study was the stringent complete response rate after consolidation, and secondary endpoints included MRD negativity, overall response rate, very good partial response rate, and complete response rate. This particular analysis was conducted after 2 years of maintenance therapy. The study demonstrated that with ongoing maintenance therapy, 2 years of maintenance therapy, that stringent complete response rate continued to improve with the addition of Daratumumab. The stringent complete response rate was 82% among patients who received Daratumumab and 61% among patients who received Revlimid alone as maintenance therapy after 2 years of maintenance. The study also demonstrated that MRD negativity rates continued to improve with longer periods of maintenance therapy extending to 2 years. The MRD negativity rate after 2 years of maintenance therapy was 64% among patients who received Daratumumab plus lenalidomide and 30% among patients who received lenalidomide maintenance alone after 2 years of maintenance therapy. The study also demonstrated that the rate of MRD negativity at a sensitivity of 10 to the minus 6 continued to improve over time. The rate of MRD negativity after 2 years of maintenance therapy at a sensitivity of 10 to the minus 6 was 36% among patients who received Daratumumab plus lenalidomide and 15% among those who received lenalidomide maintenance alone. Also importantly, it was noted that the rate of MRD negativity at 10 to the minus 6 sensitivity improved between 1 year and 2 years of maintenance therapy from 21% to 36%, whereas the rate of MRD negativity among patients receiving lenalidomide maintenance alone was roughly equivalent after 1 and 2 years of maintenance at 13 and 15% respectively. The addition of Daratumumab to maintenance was also associated with higher rates of sustained MRD negativity, both at 6 months and at 12 months. 44% of patients who received Daratumumab and lenalidomide as maintenance therapy had sustained MRD negativity of 12 months or greater versus 13% among patients receiving lenalidomide alone as maintenance therapy. It's also important to point out that in the study, patients who achieved this level of sustained MRD negativity lasting 12 months or more did not experience disease progression. The benefit of the addition of Daratumumab to lenalidomide as maintenance therapy applied across all subgroups analyzed in the study. And these improvements in depth of response as measured by stringent complete response rate, and in particular by MRD negativity rates, translated into an improvement in 3-year progression-free survival, which was 89% among patients in the DRVD arm versus 81% in patients who received RVD followed by lenalidomide maintenance in the post-transplant setting. The 3-year overall survival rate is roughly equivalent at this time. In terms of toxicity data, the addition of daratumumab to RVD induction, consolidation, and maintenance therapy was associated with modest increase in hematologic toxicity. But the combination of daratumumab RVD, as has been shown in previous studies, was well tolerated on the whole. There were very few increases in terms of high-grade toxicities, and the rate of treatment discontinuation related to toxicities was roughly equivalent in the 2 arms. With these results showing improvement in depth of response as measured by stringent complete response and MRD negativity rates at both 1 and 2 years post-transplant, and diverging progression-free survival curves showing an 89% PFS rate at 3 years of follow-up, DRVD induction for transplant-eligible patients, followed by consolidation and lenalidomide plus daratumumab maintenance, can be considered a favored treatment regimen for patients with newly diagnosed transplant-eligible disease. With that, I'd like to hand it over to my colleague, Dr. Voorhees, the senior author of the study, to discuss these results further and put them in context of other studies presented at the meeting and the overall impact of this study on the field as a whole.
Thank you, Jacob. My name is Peter Voorhees, and I'm the chief of the Plasma Cell Disorder Division at Levine Cancer Institute in Charlotte, North Carolina. I think it's safe to say that the combination of daratumumab, lenalidomide, bortezomib, and dexamethasone now represents a new important standard of care for newly diagnosed transplant-eligible multiple myeloma patients in the United States. I think that the big question that we get asked is, to what extent is this improvement in depth of response and the signal towards improved progression-free survival due to the incorporation of daratumumab into the induction and post-transplant consolidation components of therapy versus the maintenance piece of it. And with that, I think it's important to realize that by the end of consolidation therapy, not only was the stringent CR rate improved in the daratumumab arm, but the MRD negative rates were 50% at that point in the quadruplet arm versus 20% in the triplet arm. So there's absolutely no question that the incorporation of daratumumab into induction and post-transplant consolidation improves depth of response. Now, the CASSIOPEIA trial was a similarly designed phase 3 study that was performed in Europe, looking at the incorporation of daratumumab into the bortezomib thalidomide dexamethasone backbone for patients with transplant-eligible multiple myeloma. And what they had shown in that particular trial is that the incorporation of daratumumab into frontline therapy similarly improved depth of response, which ultimately translated into an improvement in progression-free survival. Now, an important difference between the CASSIOPEIA trial and the GRIFFIN trial is that the CASSIOPEIA trial had a second randomization built into it after post-transplant consolidation. So at that point in the CASSIOPEIA trial, patients were randomized to either receiving no maintenance therapy versus daratumumab monotherapy as maintenance once every 8 weeks for a total of 2 years. Now, interestingly, what they found with that second randomization is, as long as you got daratumumab, you did well from a progression-free survival standpoint. So in other words, if you got no daratumumab, either in induction and post-transplant consolidation, and no daratumumab in maintenance therapy, your progression-free survival was inferior to the other 3 groups. However, for the other three groups, as long as you got daratumumab, whether it was in induction and consolidation or maintenance or both, you did equally well from a progression-free survival standpoint. So this raises the question, what is the benefit of continuing the daratumumab post-consolidation therapy in the context of GRIFFIN-like therapy? And I think it's important to recognize that, to some extent, this is a comparison of apples to oranges. So again, in CASSIOPEIA, it was a randomization of maintenance daratumumab as monotherapy versus no maintenance therapy whatsoever, versus in GRIFFIN, patients that were in the control arm received lenalidomide, and those in the experimental arm received daratumumab and lenalidomide. We do know that there is synergy between the immunomodulatory agents as well as the CD38 antibodies. So it is conceivable that while there wasn't a clear improvement in progression-free survival for those that got daratumumab maintenance in the CASSIOPEIA trial, as long as they had gotten daratumumab as part of induction consolidation, I think that we could potentially see a difference in the GRIFFIN trial. I think it's important to recognize that the rate of MRD negativity at 10 to the minus 6 really jumped quite a bit from the end of 1 year of maintenance therapy to the end of 2 years of maintenance therapy in the daratumumab arm, from 21 to 36% respectively, whereas in the control arm, the rates of MRD negativity at 10 to the minus 6 only increased from 13% to 15%. So you cannot completely rule out a delayed effect of daratumumab in induction and consolidation to explain that result, but it is suggestive that the ongoing use of daratumumab in maintenance therapy may continue to improve depth of response and progression-free survival. There's a couple of important ongoing studies that I think will settle the debate once and for all. There is a GMMG trial, which is looking at the incorporation of the other CD38 monoclonal antibody, isatuximab, in the context of lenalidomide, bortezomib, and dexamethasone therapy in transplant-eligible patients. This study, just like CASSIOPEIA, has a secondary randomization after transplant, randomizing patients to either lenalidomide monotherapy or isatuximab plus lenalidomide. And I think that that'll be a very important result. We also have the ongoing SWOG 1803 study in the United States, which is a maintenance trial looking at daratumumab and lenalidomide versus lenalidomide for patients who've been through transplant therapy. There will be some patients in that trial that have received daratumumab as part of frontline therapy, so we'll be able to better glean the additional impact of daratumumab maintenance for those patients that had received daratumumab as part of frontline treatment. Thank you very much for listening to us today, and have a terrific day.
Thank you for listening to the Multiple Myeloma Hub podcast. We would also like to thank our supporters: Pfizer, Sanofi, AbbVie, Bristol Myers Squibb, Genentech, GSK, Roche, Amgen, and Oncopeptides.
Multiple Myeloma Hub podcasts, brought to you by Scientific Education Support.